there are many ways probably the patients benefit, but it's not just the direct knowledge, information, and experience. There's also the indirect benefit they get from improvement in general of medical care. And we've been talking about health IT as if it's about social media and a bunch of these things, but there's another aspect to it, which is the big data aspect, right. The analytic aspect, the pressures that healthcare providers and provider organizations are coming under now because of ACOs and being at risk, that they are going to have to better manage their care of patients and the quality of care of patients and the cost of care of patients. And in order to do that, they have to look at analytics. They have to understand their practice in a way that they've never had to understand it before. It's been sort of very vague, but now it has to become very specific because in order to be competitive, they've got to be able to deliver quality care at reasonable cost. And in the end, patients benefit both financially from that, from the cost of healthcare, but also from better delivery of health. And I think that healthcare IT is already having significant benefits in that regard, if it's not yet apparent directly to the individual patient who's interacting with the system.
And that's what I wanted when I said, what about solutions? I think we all know that we need to change the payment system, right? And we need to have empowered consumers of healthcare. We need to, let's try and improve healthcare, lower costs, right? The AAA. Let's do that. How does technology provide a platform for all that to occur? And I think, you look at meaningful use, and we're all going to start digitizing our health records. We're going to provide health information exchange, be able to aggregate data at a community level. And now, what's going to happen in a couple of years? We're going to have a massive data set, and so big data is the next big thing. And we really need to be prepared, I think, to handle this huge health information data set, and just like you said, apply those analytics tools. One of the things I was really excited about, one of the best presentations I saw here was on IBM's Watson and what Marty Cohn's been working on, and the whole idea of using artificial intelligence to provide better clinical decision support. It was fantastic, and it's amazing capabilities there. But that's not enough. That's not enough. And so, where's all this data going to reside? How are we going to manage this huge data set? I think that's really the next big thing. Big data is the next big thing we need to be talking about.
Absolutely.
Maybe talk about it here.
So maybe I think briefly, so I like the concept of big data. We're very big on big data, but I think there's actually big analysis. And I think the other part to that, I think, is that I personally think that technology is, on the one hand, is moving very fast, and on the other hand, the cost pressure is moving too fast to worry about education. So I think we need to do education without a doubt. But I actually think leveraging big data, that you need to build more of the intelligence into the system. There is no time, if you think about scaling up what you're talking about in terms of educating a provider, educating a hospital, about what they should or should not be doing, there is no time, given how fast healthcare costs are rising, to do this one provider at a time or one hospital at a time. You have to move faster, and one way to scale is to build intelligence into the system so that even if they make a bad decision, it will just be automatically corrected and say, I'm sorry, you don't have that option, you cannot do this. So I think that is where I think there's a real option. And one of the second part, we talk about the patients being a bad buyer of healthcare. I think one of the other parts, to be honest, is also the employers. The large employers are bad buyers to some extent of healthcare. They have put up with a lot of bad practices for a long time. Since the financial crisis, they've actually become more proactive. But I've seen, for example, the health plans who are on the receiving ends of the big employers. And when you tell them, I can give you a tool that is guaranteed to engage the patient, guaranteed to give you a 3x return in 2 years, are you interested? The response in 75% of the cases, no, it's too long, because my customers will keep churning on the commercial side, and therefore, who cares? Because I'm paying, making the investment, and he's getting the return. So I think that as that market changes, hopefully, there will be some changes. But I think it's the employers will also have to be better buyers.
I want to come back to that thought about measuring the return on healthcare IT investments, both at the patient level and at the provider level. But Dave,
well, I was just going to bring up the point, and I'll be the first to tell you that I'm not an HIT guy, to be honest with you. That when I talk to patients that I run into and they're talking about healthcare, they're thinking,
care from their healthcare provider, their physician, or the nurse practitioner, or the PA, or whoever is taking care of them. And I, keep coming back to the thing that maybe we need to start looking at things that are maybe not so much high tech, but more high touch type things. I know we have to have the infrastructure to take care of all the rest of the stuff that goes on that surrounds the whole art of delivering healthcare at the patient level, but there needs to be some focus there actually on the patient and what they're looking for.
That's right. There's a very personal side to all of this that sometimes gets lost. Johnny?
Something building on the solutions and the sort of next step discussion that just happened. Something about this conversation makes me really nervous. Someone who runs a very small business, which is the question of we need to build solutions. We need to make them innovative. We need to have them tap into big data and all these other things that it needs to do. Who on earth is going to pay for that? Because the education, and in fact, it's a chicken and the egg question. There's lots of them in healthcare. But I think going back to this education piece that you mentioned is fundamental to this problem, and it is a problem. Because, in fact, I look at this lovely Dell computer sitting right in front of me, and I think there's nobody who's going to buy this until it's built, because I don't know what it is. And you mentioned, for example, financial services and other areas that have had innovation happen over time. Only in healthcare, as far as I can see, maybe in automotive. If you screw it up, somebody dies. I mean, you in fact, in the first response market and in other areas of healthcare, I mean, certainly I think about Dennis Quaid's kids who end up getting an adult dose of heparin instead of a child dose of heparin. If you screw up the numbers, somebody dies. So what, as entrepreneurs, we keep hearing when it comes to building solutions is go out, build them, get them sold, have lots of people buy into them, and then maybe somewhere down the road, someone's going to figure out how to underwrite your company sufficiently that you can afford to keep your lights on. This is a serious problem when it comes to building innovation in this space.
Well, it finally came out.
Hold on a second.
Okay.
What you end up getting is, and my background is in the media space. So at Delta, I was coming up in media when this idea of eyeballs as currency started. There was a massive shakeout, as anyone in media will remember. The problem associated, I mean, you get some great innovations. I'm a big fan of Dr. Cronin, for example. That is, revolutionizing the idea that you can walk around your hospital with an EHR in your hand. But they're being funded every day by lots and lots of money, and they're giving away a product for free. Not everything can be built for free because sometimes it involves more than just code. And that's a serious problem. We have to figure out how we're going to get solutions that involve lots of people and lots of time and lots of education about what is possible and what it means and who's going to underwrite the time that it takes to call all of those people and go and visit them and have multiple meetings with hospitals and CIOs and CFOs and CTOs and head directors of informatics, and then the technology providers that actually have to cough up the technology that you're going to need and hopefully give you sufficient credit to wait until you end up getting paid. That's a serious problem.
Bill,
But it is, but in this case, the consequences are dire. This is not
happening. It's happening. It might not be happening here, but it's happening all around the world. I was talking to Eric Dishman the other day, and he mentioned some innovations that are occurring in China. I know you've been there, and I know others have been there looking at what they're doing. I mean, they've got a massive population. They've got healthcare they need to provide for their citizens. They have a completely different environment than we have. But that, and even in Africa, there's things. I'd love to hear Bill's spin on riffing off of what he just said, because I think there are solutions out there.
And again, I don't want to be a dead horse, but I mean, the issue that I see in much of the developed world is that first of all, I get calls a lot of times from entrepreneurs who are wanting to do deals with Microsoft or start new companies or create some doctor calling me and saying, I've just invented the world's best new EMR, and I'm like, stop the insanity. That's not what we need. One of the amazing things is to go to some of these countries and see, off-the-shelf commodity stuff being used in amazing ways. I remember a hospital I visited in Porto, Portugal, many years ago actually now, and doctors and nurses running around with slate tablets doing the discharge summaries and RFID stuff in the emergency rooms and stuff that I hadn't even seen yet here in America. And we're kind of trapped with this legacy, we're trapped with the burden of regulation, we're trapped with lots of things that hold us back. China comes to mind. I remember being with a delegation with China and the health minister and talking about all the amazing things that are possible with technology, and he simply turned to his minions and said, "Make it so." That's how they do it. And so, there's just so many examples of that where I travel around and I see amazing solutions, amazing technology, and I come back here and we get all wrapped up in ourselves in America with our crazy patchwork quilt of regulations and rules and problems. I mean, telemedicine's been mentioned here a few times. I've been a huge advocate over the years, and yet there are the most arcane, insane rules around telemedicine, whether it's practicing over state lines or reimbursements in metro versus rural, crazy, crazy stuff that the government could easily fix, but for whatever reason,
we don't want it.
Yeah.
We're talking about a $2.6 trillion industry, sixth largest nation in the world. There's no one who wants to give that up, right? Basically, the king is enjoying being the king. So then they're going to come up and say, you know what, it's time to turn that over to the next.
Well, sure, I mean, we saw that last week with the AMA, was the only group that wanted to delay CD10, and they got their way. Nobody, I don't hear anybody supporting the AMA's position on ICD-10, and they got their way.
But leave us out of politics for
But there are so many entrenched interests like that.
Right, so we have huge entrenched interests, we have huge problems, we have huge political issues.
Yeah.
So just accept that all as kind of baseline foundation, right?
Yeah.
Just like we can accept the fact that people get sick
Yeah.
as baseline, right? We can't totally change that. Let me get back to Brian's point about big data, right? So the question is, in a sense, do we have too much? Or what's being proposed out and what's on the floor upstairs, is it too much, too broad? Should the focus be a lot narrower and say, okay, can we use big data, analytics, whatever it may be, and save money and increase health in the short term? How do we get real? Because if you go to a hospital today, they need to see real ROI returns on what they do. All of this other stuff is really nice, and I'm a doctor, I care about this stuff, but let's be honest, does it really pay for itself?
And that's where my job is as a physician.
That's where my job is.
1 second.
Because, as the foundational IT spending forecast is what I do. And I am a big fan of what most of you guys put out in the room. What healthcare ought to do, what healthcare can do, what things can get better. And then my job is unfortunately to filter it and say, what will they do? What are they going to take from this? And in the US, we are still stuck with, we don't have big data. We have some data from some people who have attached IT to their systems. But we still have a great deal of hospitals without basic EMRs. We have many physicians, possibly 90% running around without an EMR running in their practice. So how can we talk about big data or population health or managed care or better use of IT when we don't have fundamental use of IT?
Well, John, where is the spending on healthcare IT right now? What is the money being spent on, and can we assume that those are the things that are generating return for these providers right now?
A lot of it is still fundamental stuff. There's still a lot going into basically covering off all the bases in EMR and radiology IT, revenue cycle management, getting ready for accountable care, which is, the way that the U.S. is going to get into managed care.
In the U.S., we are catching up with the rest of the developed world. I mean, you have to lay a foundation of digital, and we aren't there yet.
We don't have the
before we can even talk about big data.
But again, you've been to Korea, you've been to Singapore, they do managed care, very little IT. IT is not a requirement for fixing a lot of the things.
Well, but
Some of the stuff we've heard today.
But there is a requirement. So our governor is a physician. He's very interested in healthcare transformation.
Yeah.
And so he's working with Medicare for Oregon. Oregon, and so we have a healthcare transformation. It's going through the legislature right now. We have a divided 30 to 30 House split legislature, so it's tough to get things through. But we're going to get it done, and there will be legislation this session. And we're having CCOs in Oregon. CCO is a ACO with an Oregon Ducks hat on. And what we're looking at there is these groups are trying to form, that's a coordinated care organization actually, instead of accountable. Same idea, a little different, and specific to Oregon's Medicaid, public employee benefits, and all the things, and some private payers, and trying to get as critical mass. And the question is, I think that Andrew brought up about data, is what are the data sets we need to slice out of this right now to be able to do some interesting things that we can actually change payment models now. Because we need to do this now. We can't wait. All right, our state is looking at some huge cuts this year, as many states are. Federal government's operating at a huge deficit. And we need to fix this. This is a cost issue that we can't wait for. We can't say, in 20 years, we're going to have some good solutions to this. So I think there's a chance we have, an opportunity we have, to determine what the data elements are. You're right, we don't have all the big data we need yet, but the data's coming. It's a big wave that we see coming, and so we need to start building the tools right now to securely manage that data and to do analytics.
And there are going to be winners and there are going to be losers here. There are organizations that are already completely, HIT enabled and are operating and are working on the data. There's certainly the Kaisers, et cetera, but there are many others. And they're going to figure it out, and people are either going to follow that quickly, and it's going to have to be quickly, or they're going to fall behind and not be successful and be swallowed up.
So one quick point, I think the answer to your question is simple. Just like everything else in healthcare, it depends. Because you need big data for those who can handle and are ready for that, because the stages of preparedness are dramatically different around the country, right? If you go to Kaiser, they're completely ready for big data. We're already getting ready for it. You hear them talking about it. We understand population health. We've got the screening. People are coordinated. They have a team who's working on this stuff. Then you go to other places where, what are you talking about? Nobody has any HR. Consumers aren't involved. There's all the things that are fundamentally up on the floor being flashed.
I'll also guarantee you that when it's your health or your loved one's health, pretty soon big data doesn't matter,
So,
right?
exactly. So I think it goes back to your point. It's selective. So if you've got a solution, make sure you've shown that right level of solution to the person who's ready for that. But at the end of the day, healthcare, and I think to your point, it's all about culture and how we view healthcare. What is healthcare? How do we define it as a culture in this country? Right now we view it as a commodity. It's tradable and open markets, VC, and everybody else jumps into it. These other countries don't do that. They don't look at it that way. They view it as a utility. Yeah. And that's the way that they drive it.
Let me ask you a question.
And they pay like it's a utility.
Well, you just mentioned needing solutions now. So let me ask you and tell you a little story from last week, which I guess we can assume is sort of now. At least in the timeline of healthcare, right? I visited one of the largest cities in the country. This is a top 10 city in the United States. Very large healthcare system, and I can pretty much guarantee everyone here will admire, at least on a clinical level. And they're so wired up with IT. They've got 2 IT systems running next to each other inside the hospital, alongside one another, which is causing its own issues. But one of the pieces of data that they're not getting is outcomes information about what has just happened to your patients who come into the ER and where on earth do they go and who else needs to know that information. So the National EMS Information System, NEMSIS, is just putting in place its 3rd iteration. And one of the pieces of data that they require in the interest of having useful data is an outcomes piece of information. And it literally takes about 9 seconds to enter this information. It's like 3 drop-down boxes that said the patient was inboarded or they were discharged and where'd they go, or who took them home, whatever it is. It's very, very simple. And I swear, I found myself challenged to respond to the question of why would we ask our physicians to spend 9 seconds entering that information? Oh my God, really? It's 9 seconds. And it's actually going to provide useful data that you can use to allow that information to pass elsewhere through the system and get the accountability on board and get the next person in the chain notified. 9 seconds? Really? We're talking 3 questions. Right. It was an unbelievable breach of the idea that you're talking about having information that's useful, yet the people who are required to put that information in are, quite frankly, in many cases, lazy. And I know that the payer
I understand that there's an incentive problem, and I understand that. And I understand also that people they're not getting reimbursed or paid for those extra 9 seconds, and it adds up. But what I'm saying is, if we're talking about fixing a systemic problem, we have to ask systemic questions, which is, can you impose on anyone to give up 9 seconds in the interest of potentially a greater good? And that's a hard, speak of a meta question, that's as meta as you get. But I mean, it is very much a question that needs to be asked, is if you're going to challenge the fact that they're not incented, why don't we ask, how do you incent somebody to add 9 seconds to their workload?
But it's more fundamental. It's how do we define health from a value perspective? Who does what and what are they responsible for and what are they worth in the system? We don't do any of that analysis at all. Right now, it's all totally just whatever the market will bear. And we don't even have these, we're not even having these discussions.
Well, without EHRs, we haven't had the outcomes data. We're just approaching that. Yes, some health systems have it for their universe, but to be really meaningful, you really need a big N when it comes to
Well, that's what I'm saying.
we have no big data yet. I mean, there's no big
But you
data.
got to get it. You have to impose on somebody to get that.
Well, that's what
That's why we have
we're
meaningful.
supposed to see that in stage 3 of meaningful use, but the other thing, the IOM gave a big wake-up call to the health IT industry about 3 months ago. There are some bad IT systems out there. There are some poorly implemented IT systems out there, and the IOM, gave their every 10-year wake-up call to the healthcare industry just a couple of months ago. And I have a personal story. My girlfriend's mother needs a kidney transplant because she was given a MRI contrast fluid that is contraindicated for diabetics at a HIMSS stage 7 hospital. There are,
So I just wanted to challenge you, Bill, with all due respect, on a comment, just as sort of an offhand comment you made, which I don't think is, I don't think if you think about it, you'd actually agree with. You said when your family member gets sick or when you're sick, big data doesn't matter. But in fact, if the big data is analyzed...
No, out of context.
Yeah.
So it matters, but it probably doesn't matter to you personally.
No, but
I mean, if you look at, it's the old argument about population health versus individual health.
Right.
In America, we want everyone to do everything for everyone, and sometimes what is best for the population isn't best for me. That's really what
I think this gets to a very important point about personalized medicine. And, when we talk about personalized medicine, we talk about, we're talking about personal medicine, which is what we're talking about right now. But we're also talking about big data, which is what makes that possible. So I think this would be a good time to sort of have that discussion about, what does personalized medicine mean? What's the potential, and where are we right now in making that a reality?
I mean, the potential for personalization of healthcare delivery with data is huge, right? Think about the quantified self-movement and some of the things we're uncovering. I mean, we're just literally just scratching the surface on what you can do with data once you start capturing life. Once your life is digitized, and we don't even understand the implications, but that's going to have a huge effect over a long period of time. And I think it's going to be, again, goes back to who's going to be ready for that. Because there's no point giving somebody a Ferrari if they don't even know how to drive it. So we're building all this capability, but who's there? You got to educate the consumers to understand the implications. And I get really worried about the word big data, by the way. Oh, absolutely. Everybody in the ecosystem. The concern I have is big data. Data is almost completely irrelevant, right? We are awash in data now. It's not easy to access. It's not easy to analyze. So we're going to make that easy. It's really turning all that data into actionable insight at the point of decision. Otherwise, it's completely irrelevant. Who needs data? I don't want any data in my life because people don't act on data.
But you need to be able to get that learning into somebody's hands.
Absolutely.
I mean, we had talked earlier about the consumers are uneducated. Well, that's very true. The physicians left them to the internet for a little bit too long, and now they're coming at it. Nobody's listening. But we still have the fundamental problem of how do we instruct physicians what is the new best way of doing things? if we have big data and we get to evidence-based medicine, we're saying this is the best practice for dealing with this person. We put
Physicians don't like to be
genomics
told
in,
what to do. That's
and we're
the-
able to say, if you fit this genome profile, your individual best is this. What mechanisms do we have to push that information out to 600,000 physicians so that they're getting it and getting it done?
So we have a physician
Yes,
there with an
well,
answer.
I think the concept of personalized medicine,